Okay, welcome everyone at this webinar by TN2. Just a couple of remarks on the technical parts of the webinar. It's in Zoom. I'm sure most of you are familiar by now with using this platform, but it's a webinar setting. So as you can see here, only the speakers and the hosts are visible for you. What you can do if you want to ask questions, which we are of course very happy with, if you want to ask a question to one of the speakers, use the Q&A, which should be at the bottom of your screen, and you can type any question, and then as the two hosts, we can filter out the most interesting questions or the most popular questions, because if there's a question that that someone else asked and you think is a very good question, you can add a thumbs up to the question. You can also slide and adjust the visual presentation in Zoom as it's shown here. So you can, and there's a small line between the video of the speaker and the slides, and you can slide that little thing to the left or to the right, and it will either increase the size of the slides or the size of the video, whatever you prefer. Okay, so I'm Jonathan Coutinho, and together with Dagmar Verbaan, we will be hosting this session. And just a little bit about the TN2. It stands for Translational Neuroscience Network, and the whole aim is to translate between fundamental and clinical neuroscience. And we have, as most of you will know, annual conferences and webinars with alternating topics. This is, I think, the 4th webinar in a series of 9, so we're having one each month. And I'll give a preview to the next webinar, which will be in February at the end of this webinar. What we always do is it's cross-organizational. So we always have one presenter from our own research institute, Amsterdam Neuroscience, and one speaker from outside of the organization. And of course, it's free to join, so you can spread the invitation to anyone you know, and everyone can connect and participate in these webinars. So today it's going to be about the Neurovascular Disorders program, and Dagmar, you're going to tell a little bit more about that, right?
Yeah, thank you, Jonathan. My name is Dagmar Verbaan, and I'm a clinical epidemiologist, co-host for today's webinar, together with Jonathan, and program leader of the Neurovascular Disorders program of Amsterdam Neuroscience. I will tell you something about our program. It has a strong clinical focus, and it is well known for its large multi-center and multinational randomized clinical trials in order to improve both treatment but also outcome in patients with acute, both ischemic but also hemorrhagic stroke, but also in other diseases such as CVT and, for instance, chronic subdural hematoma. But next to these clinical-based projects, there's also enough room for translational research, and that's why we are here today. So I will hand back the word to Jonathan so he can introduce the first speaker.
Yeah, and for the ones who don't know me, my name is Jonathan Coutinho. I'm a neurologist specialized in stroke here at the Department of Neurology at Amsterdam UMC. Okay, so this is the program for today. We have 2 speakers, as I said, one from internal, one from external. Ed van Bavel, who a lot of you will know, he will start as the first speaker, and then we'll have Michael Hill. I'll introduce them one at a time, each before their own start. So Ed van Bavel, he's a professor of vascular biophysics at our institute. He also got his PhD in 1989 at the University of Amsterdam. And the central theme of his research is focused on the biomechanics and the mechanobiology of the microcirculation. He's involved in various research projects, including the small artery remodeling, which is an FP7 consortium, and he's currently one of the co-applicants of the INSIST consortium, which he's going to talk about, I think, a little bit as well later on. So we're very happy to have you here today, and thanks, Ed, and I very look forward to your talk.
Thank you very much, Jonathan. Thank you very much. Let me just share my screen. Start my PowerPoints. So can you see my presentation mode? I guess you can.
Yeah.
Okay. So I'll talk about acute ischemic stroke and the role of cerebral microcirculation. And I will include one slide to explain acute ischemic stroke, because I'm not sure if all of you are familiar with this field. So this stroke is caused by a clot in one of our major cerebral arteries. and is causing a devastating deterioration of the brain that's distal to this clot. The treatment for many years has been limited to thrombolysis, trying to dissolve the clot by tissue plasminogen activator in an attempt to restore perfusion of the brain. However, around 7 years ago, a new technique was shown to be clinically superior, and that's a thrombectomy, in which you remove the clot by mechanical means, by catheter and a thrombectomy device. This proved to be very superior, actually. If you look at the outcome data, this shows outcome in terms of modified ranking scale. So that's the scale of after 90 days, ranging from 0, no symptoms, to 6, dead. And if you look at the study outcomes of the combined studies that were done in that time, including our own Mr. Clean trial, it shows that the use of thrombectomy on top of the normal treatment is really superior. Taking a cutoff at a modified ranking scale of 2, you see that the increase in favorable outcome is from about 25% to about 47% in all these studies. Moreover, that thrombectomy can be applied up to a much longer time, in that time up to 6 hours. And these days, we consider doing this in specific patients up to 24 hours, while the thrombolysis was up to 3 hours. Okay, what you also see is that outcome is still very far from perfect. I mean, half of the patients has a bad outcome. This relates to recanalization. Indicated here is the outcome, again, the modified ranking scale for various classes of recanalization. Recanalization means the degree of distal filling, so the percentage of distal filling of the brain by contrast. And as you can see, the better the recanalization, the better the outcome. And there's still much to gain here if you go from what in that time was considered as a good recanalization called ETK2B to 2C and 3. So one message is that we should aim for at least 2C or 3. But still, and even in the cases where there is a good recanalization, and that's not necessarily the same thing as a good reperfusion, you see that the outcome is still bad in 50% of the patients. Of course, this relates to damage that's already there. This might relate to other things that happen in the next 3 months that are all important, of course, but part of it seems to be related to reperfusion. And related to this, what we also see is that infarct appears to grow after the first day or the first week after this even successful intervention. This is a meta-analysis by the group of Bana. He looked at the infarct progression in 24 hours to up to 2 weeks in several studies. And what came out of this study is that the infarct progression is actually quite huge. It goes from 90.5 to 37.5, so it doubles in this study. So infarct starts to progress even after we believe we have established a good recanalization. The meta-regression further on indicated that a higher average infarct also leads to more baseline volume growth. So the other way around, a higher baseline volume leads to more infarct progression. I need to get rid of my own image here. Okay, more incomplete reperfusion also leads to more infarct growth, and the longer average onset to reperfusion time also is not very good. So what's going on? This is actually a model of what happens to the infarct over time. And we use the concept of a core that's irreversibly damaged brain surrounded by a penumbra that's still in risk. So it has underperfusion, but it might be salvageable over time if you do the right thing. First of all, we believe that the penumbra exists in the first place by the presence of so-called collaterals. So these are cross connections between different branches of the cerebral circulation, making sure that in this case, can you see my mouse there? I think you do, right? If there's a thrombus here, there's still perfusion going on to the distal circulation from other branches. So the presence of collaterals in the first place is very important. It turns out that the collateral status between patients is highly variable. So there's a collateral that keeps the stuff alive for a couple of hours, and but it still progresses. It's not enough to maintain sufficient perfusion over a long time. And what you would see is that the infarct starts to grow and grow and grow. So we get more core and maybe less penumbra over time until we do the reperfusion or the recanalization. But then we still see the core growing. What's going on there is complex, and I just indicated a number of processes and how they interact. The bottom line is it's a very integrated feedback complex system. Obviously, the central thing is the local ischemia caused by the stroke that induces eventually irreversible neuronal damage. It also directly affects the microvasculature, causing collapse in terms of patency of the vessels for perfusion, but also collapse in terms of BBB breakdown. Inflammation gets into the picture, and the moment we reperfuse, the reperfusion injury also gets into the picture. The important thing here is that all these processes influence each other, and there are more processes to mention here. So this is something you want to target in an attempt to get a better outcome. But that's not easy because of all these interactions. Actually, there's this concept of the neurovascular unit. That's a concept that comes from normal brain flow regulation, and actually it still holds for this case, where all the cells involved, so the neurons, the astrocytes, all the vascular cells, the inflammatory cells, and so on, they all interact to do this one thing, get the right amount of oxygen to the right part of the brain, and this whole thing is affected by, of course, this stroke. So can we do anything to get outcome better? In the past, actually up to this point, all the trials on so-called adjunctive therapies failed. One thing that we could do is look back at what has been done over the decades in the term prior to the thrombectomy. And are there any compounds tested then that still might be reconsidered at this moment now that we have the good recanalization? We did a meta-analysis on this, and actually, or a systematic review on this, and actually I don't want to go through the whole table. The bottom line is there are many classes of drugs tested, and they can be combined in actually 6 categories: systemic hemodynamics and so on. 4 of them relate to strategies that also target microvascular perfusion, but altogether, even though there might be some hints that some might still be reconsidered, the current pipeline of adjunctive strategies is not very promising. And I know the next speaker will talk about this and come with some promising candidates, but altogether it's very limited. So how should we get this better? What we need to do, in my opinion, is that we need to better understand what's going on. We need better basic mechanism understanding in stroke progression, because there are so many questions unanswered. I also think, and you can see this from this interactive loop, that we also need to integrate our mechanistic knowledge. This whole mechanistic studies in biology in general has been very reductionistic, and there are not enough attempts to combine it. I think it's also important that we separate understanding of basic mechanisms from animal studies trying to generate new possible drugs. That are 2 different things, and you should be clear about what you're doing. If you develop drugs, I think we need to look at multiple action, multiple target approaches. And I think also in terms of how we should use our animal studies is that we need to find quantitative ways to translate mechanisms from animal to man that account for the differences in size, the differences in perfusion, the differences in molecular mechanisms, and so on. Okay, let's go to one of those mechanisms, that's incomplete microvascular reperfusion. We believe that in many cases, and this is what we see in animals, that impaired microvascular reperfusion, so a lack of reperfusion after the recanalization, either direct or in time, that relates to failure of blood vessels. So there's a couple of mechanisms that might be involved. There might be microthrombi that clog the microvessels. Endothelial cells might swell because of cytotoxic edema. There might also be clogging of vessels by inflammation, leukocyte plaques, compression by edema, and spasm by smooth muscle cells or pericytes that just close off the blood flow. We study these mechanisms, and one of our models is the so-called middle cerebral, apologize for that spelling mistake, the middle cerebral artery occlusion model. So what do? We take a mouse, we use a fiber that goes into the external carotid artery, bent over to the internal carotid artery, and then we close the tip of the middle cerebral artery, mimicking a stroke in the sense that this vessel is occluded for some time, and then we can release this fiber such that we get a reperfusion. Meanwhile, we'll use 2-photon microscopic imaging via a cranial window to look at what's happening there. And I want to show you one movie here. Well, we start looking at a penumbra area in a mouse in stroke. So what you see basically in the whole picture, there's venules, capillaries, and arteries or arterioles. You see there's flow all over the place, so this penumbral area is still getting some flow. And but it's sluggish. It is just way slower than normal. In addition, and now we are already in the reperfusion phase, that was about here. You can see that stuff happens in the capillaries. Look here, there's a clot here that gets, the blood flow gets trapped, gets stuck. There's also a clot growing in a moment here. So here it's still reasonably well. You go into almost the reperfusion. Now it stops. You see here? So something is happening here. So what you see here is a lot of clotting. And this is a model where there are no clots coming from the main thrombosis, because that's not a model. We have a fiber in there. We believe that in the cases of thrombectomy, an additional problem is that debris coming off from the large clot is also contributing to this no reflow phenomenon, if you want. This is one model that we use. The other model is actually a model where we induce or where we inject small microspheres that mimic those thrombi. In this particular experiment, actually on rats, we use 1525, 50 micrometer fluorescent microspheres. And then we look at the effect of those microspheres on a number of readouts. We do this for two purposes. First of all, we want to mimic the microthrombus release generated during the endovascular treatment. And the second thing is that actually we believe that by injecting very small microspheres, we make mini strokes. And that allows us to better understand the temporal and spatial evolution of stroke in order to find out which are the causes and effects. And that should help us understanding what's going on in the brain. I will show you some data. So it is confocal stacking data, looking at the capillary bed in red here, and the white microspheres. And in green, this is areas of hypoxia, stained by a hypoxy probe. The same thing what we see is actually very early after this event is that we have a diffuse leakage of the blood-brain barrier, indicated by staining for IgG. Around the microsphere, you see intense leakage of large vessels. But this actually disappears very quickly in the course of a couple of days. So rather than a sort of progression, what we see here actually in this particular case is that there's a kind of recovery here. So the leakage goes down, the astrocyte activation goes down, and this is not showing it right, but the microglia activation also goes down over the days. This is another image showing this in more staining. So this is the microsphere in day 1, 3, and 7. This is the control site. This is the hole that you get, so the ischemia by this microsphere. Interesting enough, the microsphere is here and the ischemia develops here. So the spatial relation between those two is pretty complex. There's a hypoxia and there's also infarction. This is the infarct here. After day 3, what you can see is actually that ischemia is disappearing in day 7. Hypoxia is disappearing. And of course, what was infarcted stays infarcted. So the one thing that I still don't know from our own data is that what you see here, we don't see progression of these mini infarcts, if you want, but we see kind of recovery of the penumbric or the mini penumbric zones in here. And I think it's very intriguing to try to understand what's the difference between here and real life patients. One thing that intrigues me enormously is this. These microspheres are in the lumen of capillaries or arterioles at day 1. but they are able to move out of the circulatory system, actually are transcytosed to the outside of the vessels. This whole process of eating up the microsphere and pooping it out on the other side by endothelial cells is really fantastic to see. In particular, in this study, up to 100% of the microspheres ended up in the interstitium this way. Okay, so this is a series of videos. The top video shows experimental data or on rats. The microvascular network, the hypoxia, the distribution, infarction sites. In the lower three panels actually show modeling work on human brains. And I think the challenge that we have is actually to use these data here, these spatial temporal relationships, combined with models that we can build from the anatomy of the brain, the perfusion territories, large vascular networks, and so on, in order to get it together. And that's something we are working hard on to get this. And I really think that this is the way to go to better integrate our experimental animal work to meaningful outcomes for patients. Actually, to take it one step further, I've only one slide to spend on INSIST. We are trying at the moment in a large consortium to use this kind of modeling. So this is a mechanistic modeling of either the tissue progression combined with other models on thrombosis, thrombolysis, and thrombectomy. We are trying to combine this type of mechanistic modeling with the generation of virtual patients. So this is models of individual patients based on a population model that gets clinical data, that gets imaging data, and so on. And then try to run the clinical trials that we believe make sense first in an in silico environment. So we are simulating the clinical trials that we want to do before we actually do them in an attempt to make the trials more meaningful, cheaper, and so on and so on. This, of course, is a big step to make, and we have a long way to go, but I think the initial INSIST results are promising, and I will be happy to talk about this on another occasion.
Ed, just as a reminder,
yes, I know. So in summary, stroke progression frequently continues after apparently successful EVT. This involves complex and interacting processes in the neurovascular unit. Targeting these processes has been extremely disappointing. Involvement of impaired microvascular reperfusion, among others, by local obstructive events, we believe is very important, and we need computational approaches to really get the preclinical data connected to meaning for humans. I think that's all I wanted to discuss, and these are the acknowledgements. Okay, thank you.
Thank you so much, Ed. I think you're right on time.
I couldn't find the clock anymore. So, okay, I hope I did. Yeah.
Perfect timing, perfect timing. So we have room for questions. I think there's one question. Oh, no, that's not a question. That's a comment. Congratulations. Very clear and interesting presentation. Well, that's always good. I have a couple of questions of myself, but before I start, I'd like to remind the audience that you can ask questions, and we do encourage people to ask questions. Use the Q&A. Don't be afraid. This is the time you can ask anything you want, at least on a professional level, to Ed. So Ed, one of the things I've always wondered is you talk about infarct progression, and you and I, we know each other longer, and we've talked about this before. And what I always wonder is when you talk about infarct progression and you look at it at a basic level, you're saying this is really happening. And what I always have difficulty in understanding is why do we rarely see that in clinical reality? Why is it always that when a patient is treated with thrombolysis or thrombectomy, they tend to improve rather than deteriorate? And if they deteriorate, we're usually afraid of a hemorrhage. So do you have an explanation? Why is it something that we rarely see clinically?
Well, I'm not sure if we rarely see it. I'm not a clinician, so it's not up to me to discuss the ins and outs. Of course, there's issues on how do we detect an infarct before or after EVT. How does the edema development get into the way, and so on. But if you look at this study here, it does indicate that there's clear infarct progression, and it is much larger than I expected, to be honest. I always thought, okay, there might be progression, but these numbers are really huge. As I said, I'm not a clinician who can judge whether issues related to the imaging, either in MRI or no, well, this is mostly MRI. If you judge this correctly, that's one thing. But my impression is infarcts progress. So maybe there are other clinicians who want to comment to this, but this is the feeling that I get as a humble preclinical guy.
I mean, I do think, I believe you that this process is happening. It's just, and we see it on imaging. I just don't understand why we don't see it as often clinically, that we don't see these patients functionally deteriorating,
Okay.
unless it's due to a hemorrhage, which I guess one explanation either could be is that the tools that we have as a clinician are not as exact or not as good as finding this maybe perhaps modest deterioration. The other reason could be that maybe that the part that's progressing is already at risk and maybe is clinically already not functioning perfectly.
Okay,
I guess
that's a good point. I take this. I think that maybe the part that's really affected could be larger than the part that shows up as infarct on the MRI. That will be, and that may be the reason that you don't see the progression in the first day or week. Yeah, but okay. Yeah.
There's a question in the Q&A, which I think is a good question, which we've studied the topic of targets for neuroprotection, cytoprotection, whatever you want to call it. Do you have an idea, like what would be your thought of novel targets that we should focus on, that basic researchers should be focusing on, which hold some promise for the treatment of stroke?
Yeah, so, well, first of all, there are a couple of novel drugs that maybe need to be discussed, but I guess the next speaker will be discussing neranotide, of course.
Yep.
My guess will be that I still consider the microcirculation as an important target. And I still believe that there's much to gain here. So it might be the micro occlusion effects. One other thing is the microvascular spasm that, at least in animals, we see happening frequently. And I think trying to target this, if you want to mention targets, we could try to still target the rho kinase systems, but we need better, more specific drugs than only the Vascular that has been used for this in disappointing clinical trials.
Right, because the rho kinase inhibitors that we have now, you always say they have such broad effects that you think it's unlikely that they'll ever reach clinical practice, right?
That's what I think. I think, well, so the advantage of the rho kinase inhibitors is that you do two things, or in general cytoskeletal influences, is that you might prevent contraction of endothelial cells and leakage. And the other thing is that you might prevent spasm or of either smooth muscle cells or parasite, or what you would like to call a parasite. So there's two ways that these drugs could be promising, but indeed, I guess we need to have more specific drugs than the general Vascular that has been used.
I ask you something, Ed. If there's an interesting target, how long does it take to translate these results preliminary from the laboratory to the clinic?
Yeah.
Is there a time frame for that, or?
I can be honest. I think if you really talk about specific molecular targets, well, up to now, after I don't know what 40 years of research on this, the time at least is more than 40 years, right? Nothing worked. A really interesting target, if it would eventually make it to successful clinical trials, you and I know that this is going to be a very long time. I don't know, more than 10 years, I guess, is reasonable. I think there's more to gain in better understanding what's going on in this whole process. So looking at the fundamental mechanisms, what is influencing what, in which time scale, and so on and so on, and maybe use this for better, I don't know, maybe better devices in terms of less release of microthrombi that get into the circulation, or maybe better patient selection for our interventions, and so on and so on, or maybe a better taking care of patients in the later phase, and so on. I think there's more to gain there than coming up with a specific new target that we find in our mice and that we try to bring to the clinic, because this didn't work out for a long time. So the first step that we have to make is actually going back to the drawing room and just understand what's happening here. There are so many questions open on this, on the collateral circulation. Or can you dilate collaterals? Actually, I don't think anybody knows for sure. So these are the questions that we need to target. Going back to basic, not even translational, I would say basic science is important. I can say this because I'm a basic scientist, but okay, I think it's important.
Okay, thanks.
I'm not sure if Michael's going to talk about it, but I think the process or the timeline of Nirenatide, for instance, has been really long. So I'm not going to say anything about it because he may comment on it, but otherwise we can talk about it after that. There's a question from Hugo Franken, who asks, is there any development in imaging techniques to more sensitively characterize the damage, especially in the penumbra at an early stage? And if so, could this help to improve treatment?
I'm not sure if I'm the person who you should ask this question, not being a radiologist. The one thing that I find is that the definition of a penumbra, I mean, it's black or white, right? We call it core, we call it penumbra, or we call it healthy. That, of course, cannot be the case. Penumbra is probably a very, let's say, continuous change from not at all any perfusion to less and less perfusion. Or more and more perfusion. It would be good if I would say in the first place that the analysis that you get, so the summary maps of penumbra and core, are better validated than they are. If you look at the CTP analysis, I'm not sure if that's still so, but it was a couple of years the case. The estimation of the penumbra depends on which vendor software you use, and it's completely different between vendors. So even if this is already the case, what are we trying to do here? I mean, we really should understand local perfusion in numbers. I think that's important. Maybe that's my short answer then.
Yeah, I think I agree. I mean, we should be very careful, and it's very tempting to interpret these CT perfusion imaging as black and white, to say it's either core, it's penumbra, or it's healthy, but that's wrong. And even though we understand where it comes from, we should be very careful because there's a lot of data suggesting that core is not always core. And of course, how can it be, right? I mean, it's not like we're using a microscope or anything. It's an approximation probably of what's happening in the acute phase. And better imaging would certainly help. The problem is, of course, you need to develop this imaging, and then you need to be able to insert it logistically in that hyperacute phase, right? I mean, we have so little time, so we need to be so fast. So that's another issue. If you have a perfect scanning protocol that takes 30 minutes, it's never going to be used in the clinic. Okay, shall we move on to the next speaker? It's the time. Yep,
It's time.
So Ed, if you can stop sharing. And then it's up to me to introduce Michael. Michael, perhaps you can put on your...
Yeah, morning. Yeah, I'm here.
So thank you very much for joining. We're very honored to have you here, Michael. Michael Hill, he's a professor of neurology at the University of Calgary, which means joining us live, depending on your sleeping habits, it's either the middle of the night or very early in the morning. I guess for you, it's probably very early in the morning, you would call it.
Yeah, it's 10 to 5.
Yeah, you're truly one of the most famous and most important stroke researchers in the world. So we're very happy to have you here to talk about this this very interesting topic on neuroprotection, or cytoprotection, as you call it. I was just going through your bio when I was preparing this, and you learn a lot about topography in Canada. If you look at your resume, because you did your undergrad in McGill, which is of course in Montreal. Then you moved to Ottawa for your medical school. Then you moved to Toronto for your residencies. Then you moved to Calgary. So I guess Vancouver is next, then.
Yeah, maybe. Vancouver to visit. Okay. Shall I go ahead, Jonathan?
Yeah, go ahead.
Okay. First of all, just thanks, Ed, for your talk. I really enjoyed that, and I think there's some synergistic things to discuss. I didn't ask any questions, but maybe at the end we can, there's a couple of things that seem to be similar to the programs here. So, okay, first I'll just start by by just showing you disclosures just for funding for our group has been, very fortunate, because we've had funding from both public sources locally in Canada, and I've been able to extract lots of money from the US NIH as well at the end there, but also from industry sources as well, just to tell you where our funding's coming from. Okay, I'm going to talk about this idea of adjuvant therapy, and it dovetails with what Ed showed, and I'm going to talk about the last box on his six. You had six sort of groupings of kind of compounds, and on excitotoxicity, and so I've called it cytoprotection, and I'll explain why. For those who don't know, this is a pine marten. Came to visit us at our cabin up in the mountains last winter. Don't see them very often. They're weasel-like little creatures, and they're quite cute. So I got a picture of them. They like to. Apparently, they're very vicious though, because they're one of the only animals that can take down a porcupine. So they can flip a porcupine on its belly and then kill it. So not an animal to tackle. Okay, so I'm going to start with the bad stuff, right? So I think many of you know this, and Ed sort of mentioned this, that there's been lots of things examined in stroke, and I think if you go back in the literature, you see that the first idea that of the so-called excitotoxic hypothesis of neuronal damage was identified in the late 50s, actually. And then it wasn't until the 90s when it became clear that glutamate binding to the NMDA receptor as a neurotransmitter was a key factor in excitotoxicity and neuronal cell death, that this really took off, and compounds were developed that blocked that interaction, blocked the NMDA receptor at the extracellular space. One of the ones that was promoted was sulfatel, and of course, as you may know, this is 21 years ago and 22 years ago now, the study was published. So it was started in the 90s. This was a tragedy because more patients in the sulfatel group died, and the bottom line here, and it was the toxicity of these molecules that was a critical factor in them never really making it to clinic. And I think, that, again, to emphasize the failure of this hypothesis, and while it looked really, really good in the understanding the animal models of stroke, when we took it to the clinic, it never got there. And Victoria O'Collins, who was a grad student at the time in Jeff Donnan's lab, did a synthesis several years ago, and was published in Annals of Neurology, of all these compounds that were so-called neuroprotective or cytoprotective or adjuvant for stroke, and they all failed. Only about 10% of these actually ever made it to the clinic, to human experiments. But the point was that there were lots of great compounds that looked like they ought to work, but never actually were able to make it through to the clinic. Now, Ed talked about this concept, this so-called neurovascular unit, and I think this way of thinking about what was happening in the tissue was promoted I think really about 15 years ago. And the idea was to say, well, listen, we've been focusing a lot on the neuron, but maybe we should be thinking about the whole tissue. And of course, it's totally logical that we should do this. And then the idea was that, well, drugs that were focusing just on the neuron were not effective elsewhere, and that was maybe one reason for failure. And I think it's fair to say that obviously we're interested in the whole brain tissue. So we are interested in the endothelium, and we're interested in the astrocytes and the basal lamina and the microglia and all of these things. And we want to see them all work. But it's still true to say that there's quite a lot of differential sensitivity to ischemia. And so it's not totally clear to me that this really is an encompassing explanation for failure of other drugs or other compounds or other approaches. But there's no doubt we have to pay attention to this. it's not clear to me that we have to tackle this as the primary focus. But nevertheless, it's there. Now, Ed showed this, and just to it's I guess it's afternoon for you, so it's not so bad to see raw anatomy. But obviously, this is a stylized picture of what has been done in the rodent models. And I guess I'd like to just really emphasize that almost all of the dominant studies that showed therapeutic effect of various compounds used an ischemia reperfusion model. So a suture was placed like this, external carotid into the internal, and blocked the middle cerebral artery here. And then the suture was removed. And so you had varying durations of ischemia, and you could see, well, if you did a 90-minute ischemia, you got this kind of infarct, and a 2-hour or 3-hour, you got various infarcts. So a key issue is that ischemia, the models for studying stroke have been ischemia reperfusion models. But as Ed again said, really 7 years ago, we saw the studies published, and it was started by your groups in the Netherlands with the Mr. Clean study. Was the idea that we had now had an ischemia reperfusion model in humans. And I think this is really important, because if you look at what happened in the translation of compounds from the past to humans, in the 1990s and early 2000s, we now know, and this is actually a complete blind spot in clinical. I don't quite understand why we didn't study this more. Perhaps it was because we didn't have CT angiography available so rapidly, but we didn't study how fast we got reperfusion with IV TPA, either with MRA or CTA, right after. So we didn't have this in our head that actually IV TPA was only opening up a proportion of arteries, and we weren't getting ischemia reperfusion. So it wasn't until we were getting 80-90% TICI2B3 flow with endovascular treatment that we really had an ischemia reperfusion model. And I think that's a critical change. And I hope that some of the things, Ed, you're studying will get, because we're now using an ischemia reperfusion model, there's a possibility to study other things. And so let me tell you about this compound that I've been involved in for about 15 years now, with colleagues in Toronto. And I think we're close to getting it to a clinical state. Let's see, I'll tell you where we are, and then you can judge yourself. To give you a flavor of timeline, and Jonathan, you mentioned this, is that this compound was first developed or first published as an entity in 1999, so 23 years ago. And of course, it was worked on before that, before you got the major publication in Science. But nerenatide is a peptide, so it previously was called TAT NR2B9C. Excuse me, it's 20 amino acids, and it was, from a science perspective, it was constructed in the lab to block an interaction between PSD95 and the cytosolic surface of the NMDA receptor. So it was designed to mimic, the amino acid binding site of the NR2B subunit, and competitively interfere with this binding. And the purpose of it was to show a mechanism of cell death in the lab, right? So in a neuronal culture in a petri dish. So the peptide was constructed as an agent to show why that you could actually block a mechanism of cell death. And the fact that it's taken, it's come all the way to the clinic is a complete serendipity, right? That it's not toxic in humans and that kind of stuff. So, I mean, it's the way science goes, right? You have to have a certain amount of luck to get it right, because it easily could have been totally toxic. Anyway, it turns out that what NA1 does is it competitively interferes with the binding between a structural protein, PSD95, which stands for postsynaptic density 95 kilodaltons. And this dissociation interferes with the activation of nitric oxide synthase. So it turns out when you get glutamate binding on the extracellular surface, calcium influx, and when you get massive calcium influx, you get overproduction of nitric oxide. I'm sure, as you know, nitric oxide, of course, is quite salutary outside the cell because it's a vasodilator. And inside the cell, nitric oxide is an important messenger. And in fact, it's important for calcium homeostasis inside the cell. But in the pathological circumstance where you get glutamate excitotoxicity, you get overproduction of nitric oxide that's quite toxic to the cell. And this is the mechanism of action. So Mark Fisher independently showed this really interesting data that if you take that rat model of stroke, an ischemia reperfusion model, and you do serial MR on the rat, and you give NA1 or control, what you can show is you get a freezing of the penumbra defined by diffusion weighted or ADC decline in the rat brain. So the idea is that this molecule stops the progression of ischemia. And of course, that's the ideal circumstance until the time that you can get reperfusion. So we first looked at this in humans, in folks, in patients getting endovascular coiling for aneurysms, and this was done in the ENACT trial. And Ed, this is very similar and interesting to what you described about microspheres, and we did this with microspheres in monkeys as well. But in humans, we were able to show that using MRI as a surrogate. So if you coil an aneurysm, you get multiple small infarcts on MR. You can actually reduce those number of those infarcts that are evident on MR. So MR is a surrogate outcome. It's not clinical. We have now shown that there's a small change in cognitive outcomes in these patients, and that data is going to be published in JAMA Neurology shortly. So we'll see that out. You'll be able to see, but it's interesting what you showed about the microspheres, because this may allow time for the healing to occur without the progression to infarction, and maybe that's why we saw what we saw. I don't know. I guess that the principal model that we worked on in primates was this one. So these are MRs of cynomolgus macaques. And in this model, what was done was the monkeys had surgical stroke. So they, each of the monkeys was brought to anesthesia, had a small craniotomy, and had a temporary aneurysm clip placed on their middle cerebral artery. So they had surgical M1 occlusion, and that clip was left on for 3.5 hours and then removed, and all the monkeys had reperfusion. And the distinction was that half an hour before the clip was removed, they were randomized to receive nerinotide or placebo. And of course, I'm giving you the worst and the best here. You see a large stroke in the placebo and a small one in the NA1 persisting out to 30 days. And this is the main point, is that on average, we saw about a 50% reduction in infarct volume with this highly controlled ischemia reperfusion model where everyone survives, right? We don't have that in humans, and every monkey had reperfusion. And I don't know, we didn't really measure anything on the so-called microvascular side of it, but it was a mechanical occlusion rather than a thrombus. The neuropsychology or the functional testing in the monkeys, green is better here. So you see that the monkeys were better at testing that they had learned before the studies. And then if you look at their stroke scores, so there's an NIH primate stroke score, very similar to our NIH stroke score we do in humans for measuring neurological deficit. And again, what we saw with the nerinotide group is we shifted all the monkeys into lower scores. So when we divided it up in quartiles, you can see that half the monkeys in the placebo group had the worst possible quartile of stroke scores. Now we did this in humans, right? So we did this in ESCAPE. We moved on from that monkey model plus the ENACT trial to then look at it in humans. And we took patients with M1 occlusions and who were getting an endovascular thrombectomy and randomized them to receive nerinotide or placebo, trying to mimic that monkey model. And I think perhaps one of the real successes of the trial was that we really did mimic that model quite well. So the onset to reperfusion, or the onset to reperfusion time in the humans was just under 4 hours, whereas in the monkeys it was 3.5 hours. and the drug delivery of neuromycin to reperfusion time in the humans was 29 minutes, and in the monkeys it was 30 minutes. So we thought we did pretty well overall in that model, but of course, as you may know, many of you may know this already, the trial overall was neutral. So our primary outcome was the modified Rankin score 0.2. You can see it's slightly better in neuromycin and slightly less death, but overall a neutral trial. Now I'm gonna show you why that might be the case in a minute. But the first thing to say was, as I mentioned earlier, it's somewhat serendipitous that we did, that we were lucky that it was safe, but it was. We didn't get into big trouble. In fact, less side effects overall if you look at the first row in the neuromycin group versus placebo. And then one of the really interesting things we found was that there was effect modification here by whether patients got alteplase or not. And you can see that in the alteplase group, the direction of effect is, very slightly negative. This is no difference between the groups. And then in the group that did not get alteplase, 446 patients, quite a large treatment effect, even a mortality benefit overall in this group. And I think in this particular group, in this stratum, importantly from a design perspective, and Dagmar, I heard you're an epidemiologist, you'll appreciate this mostly, is that we stratified the randomization on purpose so that we could try to understand if there was a drug-drug interaction at the end. So when you stratify a randomization in a trial, what you're doing is effectively you're kind of running two parallel trials, because you then have a true randomized comparison in the alteplase stratum and a true randomized comparison in the no alteplase stratum. Nevertheless, that wasn't our primary outcome or primary population of interest overall, but it became really interesting here when we showed that this effect was consistent. We had a mortality reduction. We also saw an infarct volume difference. And I think this biologically was something that really supported the overall effect. Here's the mortality benefit in this group. And then I think the other thing that really supported this concept was we were able to show, this is now going from bedside to bench, right? And I'll show you some more data on this in a second as we finish up here, that in the neuromycin group in blue, who did not get alteplase, we saw essentially a near identical pharmacokinetic curve to the people, to normal human volunteers, whereas in the red, when patients did get alteplase, we saw a substantial reduction in availability of neuromycin in the blood. And this effect was I guess pharmacological evidence that we were getting into trouble with the two drugs. And subsequently, we've shown that it's the plasmin. It's not alteplase directly, but it's plasmin that will cleave neuromycin. And so when you have active plasmin, when the drugs are given together or concurrently, we lose available neuromycin in the blood. Interestingly, a couple of slides here that have been done now subsequent to the ESCAPE NA1 trial, again going from bedside back to the bench, is if you separate the duration of time between giving the two drugs, we see this really interesting effect. So here's a rat model of stroke. It's the suture occlusion model, and look at panel B over here. And these histograms represent the volume of stroke. So sham control, no stroke. Placebo, you see that's what you expect. So that's just a saline control stroke size. Here's neuromycin, and you see about a 50% reduction in infarct volume. Now here's neuromycin given 30 minutes before alteplase.
Michael, you have a few minutes left.
Yeah, I'm just about done. Thanks, Dagmar. So here's neuromycin given just 30 minutes before neuromycin, and then here's neuromycin and alteplase given together. So preserved neuroprotective effect or cytoprotective effect here, and you lose it if you give them together. And then here's a really interesting subsequent model where we take neuromycin, and instead of using the L stereoisomer of the amino acids, we use the D stereoisomer of selective amino acids, which then changes the conformational structure of neuromycin, making it resistant to plasmin. So here's the placebo, here's L neuromycin, here's D neuromycin in the sort of crimson purple, and here's D-neurinotide and alteplase given together. So you can actually sort of take it away and show that the effect, the pharmacological effect here, is in fact related to plasmin. So we are now doing a subsequent trial, and pleased to have the Dutch group involved in this. We're just going to get you guys started in this trial. We've enrolled a little over 200 patients so far, where we're giving this compound in the same paradigm as Escape NA1, but in patients not receiving thrombolytic drugs. And we're hoping to see if we can duplicate the results of the no alteplase arm. And if that's the case, I think we're going to have a strong case that we've got a compound here which is adjuvant, a new adjuvant therapy for stroke. So in summary, I think key things that have happened were, and I really think this is important, that in humans now, we do in fact have an ischemia reperfusion model. And if you look at all the previous work, ischemia reperfusion models, drugs that were tackling excitotoxicity were effective. We never really got that in humans until recently. I do think there are multiple things that will work, and we will need to have I think looking at the microcirculation really important, and there are lots of other things we'll add on. It's almost certain that any effect we might see with neurinotide will be incremental, and then we'll need to add something else to it and something else before we can see whether we can get patients all better. And I'm hoping that we'll see something with Escape next. We've probably got another year to go before we get this trial done, and then we'll see where we are. So I'll stop there, and thanks very much.
Thanks so much, Michael. Ed, maybe you can join the discussion as well, because I think it would be helpful if we just move into like the panel discussion. Yeah, thanks. I'm just looking at the Q&A. So there's a question here. Again, everyone, free to ask questions. This is your chance to ask questions to Michael Hill and of course also Ed. But Ed's here more often than Michael. So the question is from Anke Wouters, and Michael, the question is, as more and more patients, for example, in the late window, even up to 24 hours, will be eligible for TPA, how will you deal with this large population of patients if the trial is positive? And then there's a follow-up question, what about tenecteplase?
Yeah, so great question. So first of all, I have three comments about that. First of all, I'm not interested in time anymore. I've given up on worrying about time. It's just another variable. It really all depends on what the imaging looks like about who's eligible for treatment and who's not. So I wish we would get away from talking about it. That'd be great. But I think you're right. As we use imaging to decide who we're going to thrombolyse, this may be a factor. So absolutely, for neurinotide, if you give it together with a thrombolytic agent, it's not going to work. It's pretty clear. So, and it applies actually to all thrombolytic agents, because it's not a direct effect of alteplase or tenecteplase or streptokinase or urokinase. It's an indirect effect, right? It's alteplase activates plasminogen to plasmin. It's plasmin that will cleave neurinotide. So anything that gets you plasmin in the blood is going to result in a drug-drug interaction. So sadly, as the world and we move in clinical world to using tenecteplase, which I think is going to be likely, won't matter here. So I think the hope is that, and this is what we're going to have some variant of neurinotide. Neurinotide, the next iteration will be whatever, I don't know what it'll be called. Right now it's got a name NA4, where so as opposed to NA1, as we've done iterations of that will be some version of the D isomer. And hopefully also we won't have to give it as an infusion. We can give it as a bolus injection, and then it'll be resistant to the plasmin and still provide the neuroprotective effect. That's the next trial.
Do you think the fact that it can be given as a bolus also opens up the possibility to give an even earlier, at an earlier time phase?
Yeah, absolutely. So good point, Jonathan. So we're doing a trial in the pre-hospital right now in Vancouver area. So we're giving this compound in patients who have suspected stroke diagnosed by paramedics. So absolutely, the goal would be a really interesting idea if we can see that. So we'll see. Yeah, I think that's potentially better to give it earlier. Yes. One interesting thing about the pharmacology is that at least as we understand it now, it has a relatively short half-life in the blood, but the half-life in tissue, once it gets into the brain, is many, many, many hours, up to a day. So you could give it, and then it would get out of the blood quickly into tissue, and then it stays there for quite a while. May still have that effect over time. So it could be that giving it earlier is better.
Mm-hmm.
Can I ask a question, Michael?
Yeah, sure.
I saw that one of the first studies was in patients who were coiled for an aneurysm. Is there any role for this neuronatide in patients with subarachnoid hemorrhage, do you think? Or
so Dagmar, it's a great question. I mean, so in ACT, and I have a look at it. There were 37 patients who had ruptured aneurysms. Most of the patients were unruptured aneurysms getting coiling, so they were elective cases, right? And that was clinically easier because it was straightforward to take an elective patient who was not sick, do an MRI before, coil their aneurysm, give them NA1 or placebo, and then do an MR the next day. We did take some patients with good grade aneurysms, so WFNS scores 1 and 2 and stuff, and we included them, and they had, in that 37 patients, there was a dramatic clinical benefit. The problem is that that's 37 patients. I don't know what that means, right? And so we've moved to pursuing ischemic stroke, but there's clearly a role to do a trial in subarachnoid hemorrhage. And one of the basic science thinking about what actually happens in subarachnoid hemorrhage and why you get significant brain injury is it's like traumatic brain injury, right? A sudden massive increase in intracranial pressure is just like hitting your head. It's a concussive kind of impact, and that does result in some excitotoxic injury, and it's possible that it may help. I don't know yet, but I think that's an obvious trial that we want to do. We have a trial protocol wrote it up, and we were trying to get funding to do it in parallel, but we just haven't had funding to do it. But yes, maybe.
And I guess in subarachnoid hemorrhage, theoretically, you could have 2 shots, right? I mean, it could help in the acute phase, but possibly it could also help with reducing
ischemia and vasospasm.
Right. Still, we don't really understand.
Yeah, totally right. We don't know, and I think you're quite right. Yeah.
Well, maybe Dagmar wants to talk further. I'm sure she's interested in.
Definitely. Right? Of course. Yeah.
There's a question from Erik Bakker, which I guess is first for Michael, but maybe also for Ed. Is there anything known about the concentration? You touched base on this a little bit. Is there anything known about the concentration of neuronatide that reaches the effective area? And if there are certain local processes that interfere with this, like edema?
Yeah, so Eric, I think, in the rat models, in the rodent models, you can show that you get adequate diffusion of neuronatide into the infarct core. So if you do autoradiography and label neuronatide, label the amino acids with S35, for example, you can show that it gets there, and you can show that there's adequate concentration. Nothing is known for sure in humans because you can't do that kind of study. So I don't know the answer. I certainly suspect that one of the things that's important for human stroke, if we're going to talk about drugs getting into the infarct core, is you got to have adequate collaterals to get enough drug close to where the ischemia is when you've got the proximal trunk artery occluded. The distances are much greater, right? So in a rat brain's tiny little thing, you can diffusion across a millimeter of space is potentially possible. If you're talking centimeters in a human brain, it's just not gonna occur physically. So we do have a slightly different situation with the larger human brain. I don't know the answer to your question in more detail. Maybe Ed has some more discussion about that.
Well, not really. I think it's correct. The diffusion in the human brain is not an issue. The distances are way too large, of course. So I think it would be very useful if you would have ways to get the drugs really into the core The only thing that I could think about, and this holds for any drug, of course, that you want to get there, would be to somehow use the perivascular system to get it there. I'm not sure how much has been tried, but at least we know the system is there. Nobody knows how it behaves in stroke. That's another intriguing question. So this could be maybe a possibility, inject the drugs in the cisterna magna. But okay, I discussed this with Jonathan before, and he was looking at me like, okay, come on, it's just typically a remark from a preclinical guy. How can I do this in patients? But okay.
Well, the cisterna magna is a little difficult to reach, but I mean, we can reach the CSF, of course.
Yeah.
But this is talking about the glymphatic pathway, right? Which
at least let's not call it the glymphatic pathway. Let's call it the perivascular space that we know exists, independent of the question in which way there's flow under normal conditions in this system, or let alone in stroke conditions. But yeah, I mean, that's the only channel that I can think of to get drugs to the core or close to the core in cases there's no flow around. So, but I guess patients that who don't have collaterals have a huge core and have a very bad outcome anyway. So the question is a little bit how much can we do for those patients?
Very little, I think, Ed, right? I mean, my experience with those people with isolated circulations with poor collaterals is that doesn't matter even how early, even if you get them within half an hour, you can't save them. They go on to massive infarcts, and the rate of their infarct progression is so fast that I don't think we're ever going to get to those patients.
I agree. But I would say that attempts to improve the collateral circulation, then in those patients that have and that's the majority, of course, who do have a collateral circulation, that's something else. So the question is, can we recruit collaterals? I mean, we see collateral flow. Yeah,
that's what that group with sphenopalatine ganglion stimulation was doing, right? With trying to open up collaterals, but we'll see where that goes.
Yeah. Michael, do you know, because you touched base a little bit on that, the concentration in the neurons, or at least in the brain, is high for a much longer time. But are there thoughts on whether like a single bolus of norepinephrine is going to be enough, or are there thoughts about maybe repeating it, like giving it?
Yeah, well, we talked about that. I mean, those data are based on animal data, right, Jonathan? Because that's where you can measure concentrations, right? You can sacrifice the animal and see what concentration there is in the brain. We don't have human data to know that. I don't know. I mean, maybe we need to do that, is give another dose, after you've 2 hours after the first dose. We don't actually know that, and there will be opportunities to study that perhaps. So far in the animal models, repeated dosing doesn't change the outcome.
At least that would be probably interesting for aneurysmal subarachnoid hemorrhage, where
I think that's right. I mean, and Dagmar, you've been interested in that, but I think we've got to, it's something that will need to be studied in the future. Absolutely.
Mm-hmm. I actually had a question about something that I had heard, and I'm not sure if it's correct, but it's something I heard. It touches a little bit on science, but also on the emotional part. And it's about that monkey experiment that was run, which I think was in Toronto. And I was just wondering, what I heard is that the neurosurgeon who did those operations actually had a hard time, like from an emotional point of view, right, doing those surgeries. And I was just wondering, because there's a lot of talk about animal experiments, and it's something I could totally imagine, but I never know if it's actually true. Was that an issue?
Yeah, I mean, I think primate. I mean, the genesis of all this came out of the STARE, recommendations, which, after all of the failures of so many agents, right, the stroke industry academic roundtable recommendations said, okay, you need to stop it with the mice and rats, and do primate experiments before you go to humans, because we've had so many failures. You've got to show this. And I mean, this was this scientific pressure was the reason to push this way. And I think you're right. I mean, if you talk to DJ Cook did these experiments, and I mean, these cynomolgus macaques they have personalities, and they clearly are incredibly, well, they're human-like, right? They just like you have your dog and your pet cat, you have a relationship with that animal. The same was true here. And the studies were done with incredible veterinary control. So I think the ethics of it were had amazing oversight. Yet I think there's lots of room for discussion about the ethical approach, and is it appropriate to treat animals in this way? What was remarkable, of course, is that the animals that got NA1 did incredibly well. And that was, of course, very gratifying to see. But you're right, the animals with placebo, right? I can tell you an interesting feature of it is that the cynomolgus macaques have a just at the very proximal M1, they have a, in humans, we have the recurrent artery of Hübner, right? Often coming off either the A1 or proximal M1. They have a consistent anatomy that that's like that supplies the deep caudate and deep structures. If you put the clip proximal to that recurrent artery, all of the monkeys would go on to have a malignant MCA stroke. And so the clip was put just slightly distal, right at the proximal M1, but distal to that recurrent like that equivalent recurrent artery of Hübner, to make sure that the monkeys had a more moderate stroke, otherwise that they would suffer a malignant MCA infarction and die. So that was a critical experimental thing that had to be done. But you're totally right. And I think the one thing that comes out of this, if we can show ultimately that nerenatide at least has some effect, it's not going to be the whole answer. It never will be. We'll need to get all the other stuff. But if it has some benefit and we can bring it to the clinic, it's now a sort of repudiation of the argument that you need to use monkeys. And that's why I would say that I think, a dominant thing here is that now we've got an ischemia reperfusion model in the human that really is much, much more similar to the ischemia reperfusion model in the rodent. Mm-hmm. And you see that the effects and stuff are very, very similar, right? It's not that the rodent model was wrong. It's just that we were really, really crappy at translating that rodent model because we didn't have an equivalent model in the human.
Yeah. It's definitely an interesting part of discussions on animal research, and touches base, I guess, on what Ed is doing with his INSIST study as well, right? Which I guess in part is aims to reduce animal experiments and maybe possibly also human experiments.
Sure.
Okay, I think we have time for one closing question or a closing remark. I don't know if anyone wants to bring something up. If not, then I was wondering maybe either Mike or Ed, if you have a recommendation, because we have a lot of translational or basic stroke scientists looking at these webinars, and you've both gone through a long phase of this kind of research. Do you have like any tip, like any, what should they be thinking on? Like, what should they avoid? Anything like that?
In general terms, that's a good question. I think everybody should realize that these things take ages, right? From the first ideas to the animal studies to hopefully eventually to the clinic. So whenever you work on this, you have to realize you can only make a small step. That's just how it is, and it's hard work, and it will fail much more often than it doesn't. But don't get frustrated. Personally, I get motivated by what I see. So I showed you this extravasation of these microspheres. It was published before, but seeing this, I find this really intriguing. And then I really want to know, so what's going on there? And can we use it, for instance, for drug delivery, to mention something? So that's what motivates me to do this kind of work. Maybe that's my best suggestion. Get motivated by the data that you see. Think about what they mean, how they could mean, how they could be relevant in other situations. Serendipity is an important thing. So keep an open mind for what you see. Is that kind of a last word that you want to hear from me?
That's a good tip. So also perseverance. Huh?
Perseverance, definitely. Sure. Yeah.
All right, then I'm going to show one more slide before we close, which is this one. And that's on the next TN2 webinar, which will be February the 17th. Same time, it's always a lunch webinar. Registration is open. You can look on the website and you'll get an email, of course. And the next one's going to be on neuroinfection and neuroinflammation. Okay, I guess that's it. Thank you all for joining.